Hello, good morning everyone. Today we are going to start with the clinical condition, the abnormal condition that affects the Vickers diagram. So we know that Vickers diagram, understanding Vickers diagram, it is all about study of the changes in the pressure in the ventricle, atrium, in the aortic artery, in all these vessels, and also the ECG graph. All this thing correlates and depicts the events that happens during one heartbeat or each heartbeat. Now, in abnormal condition, in abnormal conditions affecting the Vickers diagram. Now, one thing that we have learned and understood about the Vickers diagram is that the pressure changes of the and in the left side of the heart is depicted. Like when we are studying the ventricular pressure change during a cardiac cycle, we are studying the left ventricular pressure change. Why that is so? Because it is the left ventricle that is having the difference in the pressure many folds than that of the right ventricle, though the event is same in both the ventricles. Now, first, we will start once again with the pressure events that is in the left ventricle so that we can correlate to the abnormal condition well. So, just as a reminder, okay, this graph we study just as a reminder. So, as we know, this is the left ventricular pressure change. So very quickly, as we can see here, this has been marked as like A, B, C, D in the graph, only the ventricular pressure change. So A as we studied, what is A? This is the healing of the ventricles. Okay, this is a feeling of the ventricles. B, this is the hump. Now, this hump correlates to what? This hump, it is the atrial systole, as well as this is the active filling of the ventricle. If you see the previous video that we have studied, you will understand, you will remember that this B point, it signifies the atrial systole or the active filling of the ventricle. Now, C, the point C here. Okay. Abri Zirak Salat. Okay, hello. Abri Zirak, you do one thing. Now, the ventricle pressure that we are discussing here, you understand that one. And in the previous lecture, we have discussed each and every step in details. You go through the previous video, you can understand it well. Okay, because now we have to move ahead with the other portions. But right now, what I am explaining are the events again in a very review manner, what actually happens when the left ventricle pumps. So C, what does C marks? C is also the first heart sound, and if we remember what makes the first heart sound, it is the AV valve closer. Okay, it is the closing of the AV valve at the point C that marks the and causes the first heart sound. Now the point C to D, I'm writing it here, C to D. If we remember what is happening in C to D, the AV valve is closed, and previously in the protodiastole, the semilunar valves are closed. So now the ventricle is a closed chamber. So C to D is actually isovolumetric contraction of the left ventricle. Isovolumetric contraction of the left ventricle. Here what happens? Here the pressure in the left ventricle increases, though there is no change in the volume of the blood that is present in the ventricle. So here first the pressure change happens and the pressure in the left ventricle increases. Again from D to E, the gradual increase in the pressure in the left ventricle continues. Now, what is the other event that is happening in the E? Now, E here, this is the point when the ventricular pressure, left ventricle pressure at E, the left ventricle pressure is greater than the aortic pressure. So, the aortic valve opens. So, E is the point where the aortic valve opens. On the left side, it is aortic valve that opens, and on the right side, that is the pulmonary valve that opens. An opening of valve, what we studied, it causes no sound. So here you see corresponding, there is no sound. Now, the point E, the point E to F. As we can see here, the ventricular pressure further continues to increase until it touches the maximum point F. Now, this is the E to F, where rapid ejection from the left ventricle happens. Okay, it is a rapid ejection of the blood that happens from the ventricle. And F is the point when the pressure within the left ventricle is maximum. Here, the left ventricle pressure is maximum. Now, as soon as it touches the F point, then what follows is a gradual decline. What follows is a gradual decline. So, from the point F to G, again, the pressure in the ventricle starts falling. Usually, the maximum pressure at F is usually 120 mmHg and at E, it is 80 mmHg. Now, once this maximum pressure is touched and rapid ejection happens, then there is a gradual drop in the ventricular pressure. The pressure in the left ventricle drops. Okay, but slow ejection of blood continue. So, though there is drop in the ventricular pressure, yet there is continuous slow ejection of blood. So, the phase F to G is the slow ejection. And additionally, in the previous class, what did we study? It is the rapid ejection plus the slow ejection that makes the stroke volume. So, point to remember, it's a revision for us. Rapid ejection plus slow ejection makes a stroke volume. Okay. Now, from the point G or at the point G, the event that is happening, that is the closure of the aortic valve, because as soon as the pressure in the ventricle touches 80, and when the pressure in the ventricle touches 80, the pressure in the aortic artery that was following the pressure in the ventricle, like when the pressure in the left ventricle was increasing, the pressure in the aortic artery was also increasing. But when the aortic artery pressure touches 80, after that the pressure in the aortic artery, like aorta basically, it does not fall. It closes the valve at a 80 mmHg and maintains at that. So, G is that point which corresponds to the second heart sound. Now, once again you see at C, the AV valves were closed and now the aortic valves are closed. Now, once again, the ventricle is a closed chamber. So, hereafter, from the point G to H all the way till I, okay, there is drop in the pressure. So G2H, there is isovolumetric relaxation, means the ventricle cardiac muscle, they are relaxing, but there is no change in the volume of the blood that is within the ventricle. That means the filling has not started. Okay. So here G2H, it is an isovolumetric relaxation, and H2I is also isovolumetric relaxation with further with further drop in the left ventricular pressure. Now, when the pressure reduces to minimal, that is at the point I, this is the time again when the AV valve opens, and the what follows is the filling phase, the passive filling of the ventricle, which we saw in A, that starts, and once again the cardiac cycle starts. So this is a pressure change. This is a graph that explains the pressure change in the left ventricle. Now, there are certain conditions which alters the Weaver's diagram. When we are talking about Weaver's diagram, we mean like everything we studied. The changes in the left ventricular pressure, the changes in the left atrium, all this together, there is a change in the pressure whenever there is any abnormal condition. So, for example, here we will study two conditions today related to the mitral valve. The first one is here. The first condition that we are going to study here is the mitral valve regurgitation. Is the mitral valve regurgitation. The term regurgitation means regurgitation means backflow. It means backflow, means when the blood is moving backward, not forward. So mitral, where is the mitral valve situated? Mitral valve or bicuspid valve. Mitral valve or the bicuspid valve is at the junction between the left atrium and left ventricle. This is where it is anatomically located. So, on the left side, you see the normal diagram. You can see the normal diagram. So, here what do we see? Here we see during the ventricular contraction, just during the ventricular contraction, when the ventricles are contracting, here you see the pressure difference is like 120 by 10, right? So, there is isovolumetric contraction. The pressure in the left ventricle increases to 120, which pushes the blood through the aorta, right? And when this is happening, this is where the mitral valve lies. This is where the mitral valve lies. So you see the mitral valve is totally airtight. It is snapped. It is closed. There is no leakage or gap or any anatomical anomaly or anatomical disformity, right? So this is how the mitral valve is lying. Now see in condition when there is a stenosis of the mitral valve, like if the mitral valve is like regurgitated, like it's not like snapping properly. Now snapping properly can happen due to stenosis also. Stenosis is our second example. We will come to this details later. Or let's think in such a way that mitral valve is not closing properly due to some defect in the flaps of the mitral valve. The anatomical configuration while embryogenesis would have happened in a such a way that even during isovolumetric contraction and isovolumetric relaxation, when the mitral valve should be closed tightly like the normal picture, here the mitral valve is not airtight, not closed tightly, and there is a gap. There is a gap between the flaps, you can say between the flaps of the mitral valve. So here you can see there are like actually gaps between the flaps of the mitral valve. So such condition, what will happen even when there should be isovolumetric contraction or isovolumetric contraction already begun, because blood is liquid, it's not solid, so it will blood from the left ventricle will always have a tendency to move backward back into the left atrium through the gap between the flaps of the mitral valve or bicuspid valve. So even after proper filling of the left ventricle by the blood, then there will be a certain volume of blood that is going back to the left atrium. As a result of what? As a result of this, what will be seen is that the pressure in the left atrium in normal condition should be maintained at 10 mmHg during the ejection period of the ventricle. But since some blood is going back into the left atrium, the pressure is now more than 10. It is like 25 mmHg. So here you see 15 mmHg pressure is like more in the left atrium than normal condition, because blood is now going back to the left atrium. Now this volume of blood that is going back to the atrium, now this is not available into the left ventricle for pumping in the periphery, as a result of which there is drop in the end diastolic volume. End diastolic volume, you remember we studied, it is the volume of the blood that is in the ventricle after the ventricle is filled both passively and then actively. Okay, so since there is a gap, the blood is flowing from the ventricle to the atrium, and the volume of the blood is also less in the ventricle, as a result of which, if the volume is less, automatically the pressure is less. The pressure is like less. So instead of this 120 by 10, like 120 by 10, the 10 is the pressure in the left atrium. Here you see the pressure in the ventricle is 110 and the pressure in the left atrium is 25. So actually the left atrium pressure has increased and the pressure in the left ventricle has decreased. So overall, how do we remember? We just remember here, due to less volume of blood in the end diastolic volume, the left ventricular pressure decreases and the left atrial pressure increases. Now, here what happens during the stroke volume, when the blood has to go via the aorta into the peripheral circulation, there is not enough volume of blood, as a result of which the maximum pressure till which the ventricle must reach, that is 120, like it should be the pressure in the ventricle as well as in the aorta for proper pumping of the blood into the periphery, that will become less, that has become less in case of mitral regurgitation. So when the volume is less, automatically the ventricle will have a tendency to exert more pressure. The ventricle will have the tendency to exert more pressure. Okay, so the outcome will be the systolic blood pressure. Okay, the systolic blood pressure will decrease. The systolic blood pressure will decrease and stroke volume is less. Obviously, it is less because not enough blood in the ventricle to pump out in the periphery. So, less pressure and less amount of blood in the stroke volume affecting the systolic blood pressure. So, the same thing, how will it reflect in the Vickers diagram? So, here in the Vickers diagram, as you can see, since there is a opening, there is a gap between the flaps of the bicuspid valve. Here you see what usually we know the significance of the V wave. What is the significance of the V wave? A quick reminder on the side. What does V wave signify? V wave is due to ventricular contraction. Right? Meaning what? See, this red diagram, this one, this is the pressure change in the atria, right? This is the atrial pressure curve. This is the aorta pressure curve. And this blue one is the left ventricle pressure curve. So, when there is not enough blood and there is always a gap for the blood to go back, the ventricular wall, it has to do a more work. It has to pump like more forcefully to make sure whatever blood is remaining goes pump into the peripheral circulation. Now, in doing so, the thickness of the ventricular wall, the ventricular wall thickness increases. Okay, this is one thing. And the V wave, it becomes steeper. Why does the V wave become steeper? Because the bicuspid valve, because they have a gap, they are now pushing more backward on the atria. As you can see here, in normal condition during contraction, the pushing of the left atria by the bicuspid valve is there, but it is minimal because when the ventricle is contracting, the bicuspid valve is bulging upward. But when there is a gap between the flaps and the flaps are like pushing themselves more inside the left atria, exerting more pressure. So when the ventricles are contracting, the pressure exerted by the opened or like the leaked or like the not tightly closed bicuspid valve is more on the left atria, as a result of which there is more increase in the V wave. So what is the characteristic of this? Here, the V wave is affected. Okay. And there is a steep climb to the V wave. So, a steep climb to the V wave due to increase in the pressure in the left atrium. Coming to the aortic pressure or pressure in the aorta, it is the aortic pressure is not affected. Yes, it is true that it is not reaching to the maximum 120, but it is not abnormally affecting the aorta because the aortic valves are functioning normal. Whatever blood the ventricle is pumping, it is going correctly through the aorta. So, no change in the aortic pressure. No change in aortic pressure. Okay, and the filling phase of the ventricle is not affected. The filling phase of the ventricle is not affected. So, no filling phase of the ventricles are not affected. Okay. So, no significant change in the diastolic blood pressure is seen. Coming to the second example, that is the stenosis of the mitral valve. So, our second example is the example 2. This was example 1 and this is example 2, which is mitral valve stenosis. Now, mitral valve stenosis. What happens in mitral valve stenosis? During the embryogenesis, like when the fetus is in the embryo and the differentiation in the fetal character is happening in the structure, yeah, stenosis means there is like narrowing down of the bicuspid valves. The mitral valve, the flaps are present, they're not absent, but the configuration, the anatomy is different. It is not correct. It is not correct. So, as you can see in normal condition, that is on the left. What happens in the normal condition? Now, in a stenotic, mitral valve stenotic heart, it is like the mitral valve is always open. So in normal condition, what happens? As we studied, a pressure of 10 mmHg is maintained in the left atrium, and through this mitral valve, there is like feeling of the blood from the left atrium to the left ventricle. The feeling part is not affected because the gap has not been reduced or closed during the relaxation period. So the feeling phase is like undisturbed. There is no difficulty in the feeling phase in the normal condition. In case of a mitral stenosis or stenotic valve, here you see there is anatomical anomaly because of which not only there is a narrowing of the mitral valve and it closes and opens not perfectly. There is always a leaking that is happening in case of a stenotic valve because the opening is narrow. Here if you compare the radius of the valve, the gap between the two flaps of the valve, it is much wider during the feeding phase. And here in the mitral stenotic, here you see, because of the anatomical abnormality, here you see the gap has reduced. The gap is much lesser than that of the normal condition. So it affects the feeding phase a lot. How does it affect? Now, during the feeding phase, the blood which has to pass through the narrow gap, it faces more resistance. It faces more resistance. And when it faces more resistance, the blood flow in a turbulent way, like in a haphazard way, not in a linear way. Here, as we can see the normal condition, the blood is flowing in a quiet or in a streamlined way because there is the gap between the two flaps are normal during the filling phase. But in case of a stenotic valve, the gap between the two flaps of the mitral valve is narrow. As a result, the blood is facing more difficulty to pass through the narrow gap. So, here during filling phase of the ventricles, the blood faces high resistance. High resistance due to stenosis. And the blood flow is turbulent because there is narrow gap and the resistance is more. So how does it reflects on the Vickers graph? Here, if you see, here you will see the aortic, the pressure in the aorta, this is normal. Now, as the valve is happening to face like more resistance, the filling of the blood is not proper. So, here in this case, the end diastolic volume is reduced. Okay. Since the end diastolic volume is reduced, the pressure is also less. So during the isovolumetric contraction, the pressure does not climb in the left ventricle as well as in the aorta. It does not climb up to 120. It is always lesser than 120 mm, 120 mmHg. And since again there is like stenosis, not enough blood is flowing from the left atrium to the left ventricle. So there is always a build-up. There is always a build-up of blood on the left atrium. So pressure in the left atrium increases because of the stenosis. Not enough blood is able to come. So what happens to the JVP waves, or what happens to the atrial pressure? Here, this blue line, as you can see, this is supposed to be the normal pressure with a normal area. Here, the overall left atrial pressure, you can see the gray area, this gray area. This is like the increase. This is like the increase, the gray area. This is like the increase in the pressure of the left atrium due to the stenosis. Due to the stenosis, so all like A, V, C, X descent, Y descent, all these characteristics graphs, they increase in their pressure. The nature, there is no deformation as such. You say there is no deformation in the wave, but the whole base has increased. That means all the pressure in the left atria has increased. And this is, and there is a murmur heard during the contraction of the ventricle. So we do get a murmur in a patient who's suffering from mitral valve stenosis. And if you look at the pressure of the left ventricle, there is no change in the pressure or no deformation in the curve of the pressure depicting the left ventricle. Means it is not gone up or not gone down. Yes, the pressure load on the left ventricle is increased, but the filling pressure, the end diastolic volume is not adequate. Since the end diastolic volume is less, the amount of the blood that should come to the ventricle is less because of the stenosis. It affects the systolic blood pressure. So, systolic blood pressure decreases, stroke volume also decreases. Okay, rather stroke volume decreases first, and as a result of which the systolic blood pressure decreases. So these are the two examples in which we understood the abnormal condition that affects the Vickers diagram. Okay, now moving on to the loop, like we started with the changes in the left ventricular pressure, understanding that, after which we connected to the Vickers diagram. Now this whole loop, this whole ventricular pressure, it is studied as a loop to correlate to different clinical conditions. Now, first we will understand the normal loop, and then after understanding the cardiac output, we will connect it to the abnormal conditions of the loop. Okay, so first the pressure volume loop. Again, here when we say the pressure volume loop, we mean in context to the left ventricle. So going by the diagram. Okay. The weakest diagram that we studied and understood as the left ventricular pressure, the previous one that we started the class with. Now the whole thing can be understood in a loop. Actually, it is a loop that gives the better understanding or explanation in context to the clinics. Okay. So here, if we look at the left side, the rounded up one, this is our left side of the diagram, like this one, the left one, where the x-axis designates the volume and the y-axis it designates the pressure. It is the pressure. Okay. Now, if we go by the events, the beginning of the loop is such that it starts with a point. Yeah, this one, it point which was written as like B point in the weakest diagram. Now, this is the point where the mitral valve or the AV valve opens. So, right after the AV valve or the mitral valve opens, what happens? The filling of the ventricle happens, right? The passive filling phase happens. So, this passive filling phase is the phase 1. Then again, after the filling is over, just before the isovolumetric contraction, what happens? The mitral valve closes. So, this point is the closure of the mitral valve. So, once the mitral valve closes, again it is a closed chamber. So, now in the phase 2, what do we see? Phase 2, phase 2 is our isovolumetric contraction. After isovolumetric contraction, what happens? Aortic valve opens. After aortic valve opens, what happens? The next phase is again the ejection phase. That is the phase 3. Ejection phase means rapid ejection, slow ejection, which makes up the stroke volume. Okay. After that, the next event that happens is the snapping or the closing of the AV valve, which causes the first heart sound. Okay. Now, after this phase 4, this is the isovolumetric relaxation. So, this is the event in the loop. Now, when we study or when we face exam, we will not be given the loop on the left side. This loop on the left side is for us to remember better. Now, cardiac function will be given as like the loop, which is the volume pressure loop, will be depicted as something like we have it on our right. On the x-axis, it is a ventricular volume, and on the y-axis, this is the ventricular pressure. Now, going by the event, if we go by the event, then how do we remember it? How do we write it? Like A. Can you see? Yes, this pressure A, this point A. So, what is the point A? Now, point A is the point where the AV valve opens. See, these things we are studying and repeating over and over because understanding these points, this pressure loop, this Vegas diagram, and these points in the diagram are of absolute necessity. So, in A, the AV valve opens. After A, now A to B or B point is what? B point is the healing phase. Okay. Again, B to C, what does it signify? The arrow that is going from like B to C, increase in pressure where in left ventricle due to filling of ventricles by blood. Okay. Now, what happens in the C? C, the event that is happening, we know it as this is C. What is happening in the C? Here, the AV valve closes. Now, when the AV valve closes, then again, what happens from C to D? Isovolumetric contraction. Now, D, what happens in D? The aortic valve opens, then D to E, rapid ejection, E to F, slow ejection, and both of them makes the stroke volume. Makes the stroke volume, right? This is what it makes, like D to E and E to F. After that, what happens at F? Again at F, there is aortic valve closes. Aortic valve closes. And again, from this F to A is isovolumetric relaxation. So, isovolumetric contraction, isovolumetric relaxation. Now, what is the significance of this loop? Why do we need the loop? The significance of the loop is that the area within the loop signifies stroke volume. Okay, so this one it signifies the stroke volume. Now, this is not a it has a drawback also. The drawback is that it is not a very good measure or very good depiction of how much work is done by the ventricles. Another point that we should remember here is that it is the point to remember. It is the C to D. It is the C to D. Here, the maximum energy is needed. Okay, because pressurizing for contraction is actually consuming more energy than actually the ejection phase. This is what we understand from this graph. So this is our normal graph, the phases that we have understood. On the left, for our understanding, we have understood the labeled loop, and on the right, because we have to correlate to this one when we are writing exam or facing any kind of licensing exam, or even in the abnormal condition, this is the loop without any labeling we are going to get. This is a normal loop. Now, we will understand the cardiac output. After finishing the cardiac output and discussing the factors of it, we will study the abnormal conditions related to this loop. Okay. Now, what is cardiac output? Cardiac output, going by the definition, it is the total amount of blood pumped by each ventricle per minute. Now, this is where is the biggest difference with the stroke volume. Stroke volume was per beat, whereas the cardiac output, it is like per ml. So, we all know it. What is the normal value of it? It is about 5 liter per minute. This is the value of it. This is like how much it is, 5 liter per minute. Okay. What are the significance or what are the applications of cardiac output. So anything that affects the stroke volume will affect the cardiac output. Now in context to cardiac output, another terminology that we have to understand and remember is the ejection fraction. Okay, so understand that. Let's go by the diagram. Okay, say this is the ventricle, right? Just highlighting on the, emphasizing on the ventricle. Now the end diastolic volume, as we studied, okay, this is the end diastolic volume. Okay, so it is from the end diastolic volume. That means end diastolic volume is how much? About 130 ml to 150. Say for example, say in this person it is 130 ml end diastolic volume. Now from this end diastolic volume, a fraction of blood is pumped out as stroke volume. So it is from this end diastolic volume, which is about 30 ml, 30 ml. So out of 130 ml end diastolic volume, say 70 ml of stroke volume is ejected, right? Per beat. Okay, let me mention the per beat. It will be easy to remember. Per beat, right? So this 70 ml has come from where? This 70 ml has come from 130 ml. So we can say this is the fraction of the blood that is pumped out as stroke volume has come from the cardiac output. So that fraction of the blood is called as the ejection fraction. So ejection fraction, what is it? Ejection fraction is the fraction of blood pumped out as stroke volume from the end diastolic volume. So since it is a fraction and it is being pumped out from the end diastolic volume, we understand it and clinically correlate it in terms of percentage. So 40 to 70% of ejection fraction is normal. What do we mean by that? We mean that example, if end diastolic volume is 30 ml, then 40% of 130 or like 40, the whole range, 70% of or up to 70% of this 130 is normal ejection fraction. Okay, this is normal ejection fraction. Now, what is its applied use? What is its applied value? Now, this is significant in understanding the myocardial contractility. Okay, like, how is it important? Like, in heart failure, the ejection fraction is less than 40%. Okay. Now, there are some agents also which can increase the ejection fraction, like substances like caffeine, okay, or positive ionotropic agents, like substances that increases the contractility of the heart, which increases the force of contraction, increases the ejection fraction, and similarly any heart disease or defect in the valve decreases ejection fraction. Okay, these are the important points to be remembered. Now, coming to the determinants or factors which determines the cardiac output. Okay. Cardiac output, it is calculated as or represented as heart rate into stroke volume. Okay, so obviously any factor that is increasing or decreasing the heart rate or increasing and decreasing the stroke volume will obviously affect the cardiac output, though it is seen that it is seen that increase in heart rate increases cardiac output more, okay, than increase in the stroke volume. So if the heart rate is more, then it is seen the cardiac output increases rather than when the stroke volume is more. Like both heart rate and stroke volume increases the cardiac output, but increase in the heart rate affects the cardiac output more. Okay. And stroke volume also, but the heart rate it affects the cardiac output more, but both are directly affecting the cardiac output. Now, other factors, physical factors like that affects the cardiac output. Physical factors affecting cardiac output. What are the physical factors? They are number one, like sleep to awakening. Posture. It is seen that when a person stands up from lying condition or sitting condition, the cardiac output increases. Okay? Posture. Then temperature. It is seen that usually if a person is exposed to hyperthermia, the cardiac output increases, and opposite hypothermia, the cardiac output decreases. Okay. Overall, factors that increase cardiac output are, like physiological factors are pregnancy, exercise. But these are the physiological factors. Means which will get back to normal after pregnancy is over and exercise is terminated. Other factors, positive ionotropic drugs. Example, digitalis. thyroid hormones. By increasing the heart rate, it is seen to increase the cardiac output. Similarly, factors that decreases cardiac output. What decreases cardiac output? Sorrow, emotional factor like sorrow, grief. Okay. Negative ionotropic drugs like certain vasodilators, all this thing, they decrease the cardiac output. Okay. Now, before going into the determinants of the cardiac output, very quickly we'll have a look at the measurements of cardiac output. How do we measure the cardiac output? So what are the various methods to measure the cardiac output? The various method to measure the cardiac output that once have been used was the Fick's principle. Okay. We'll just have an idea about it in a very brief way. Then that was in use was the thermodilution technique. Fourth, what we have is the what was there is the echocardiograph. And the one which is used maximally is the MRI. Now, out of all this, the actual correct one was the Fick's principle or the Fick's principle or what we call as the Fick's method. What was that? There was a formula. Very quickly, we will just go through the formula. The formula for the cardiac output was that VO2 by the difference of the oxygen concentration in the artery by difference of the oxygen concentration in the peripheral or the mixed blood concentration in the pen, atrial blood and the venous blood, the atrial blood and the venous blood, in which VO2, it is the total oxygen consumption by the body. Whereas it is divided by the oxygen consumption by the arterial blood, that is oxygenated blood, that's why we write it as CaO2, and by oxygen consumption or the oxygen value by the mixed blood or venous blood as it is deoxygenated. Okay, these are the formula for it. But there is a disadvantage in this method. This method is accurate, most accurate, but is invasive. Now, since it is invasive, it can be painful also. It is rather painful. So, this method became obsolete, though it is like the most correct method. So, the second method that evolved is the thermodilution technique or thermodilution method. So here actually the principle was that a cold saline was injected through the pulmonary artery all the way till the right atrium, so that it mixes with the circulation, and by change in the temperature the concentration of the inject of the dye that is used, this calculations about the cardiac output and everything was made. So here a cold normal saline, we know how much it is, 0.9% NaCl, that is what is the normal saline, right? So this is a cold normal saline at the rate 10 ml for 4 seconds, that is at room temperature, or at the rate of 5 ml for 2 seconds. Now this is if it is like normal at normal temperature, and this is the ice cold saline. So by that this saline was injected, and a catheter a catheter with a thermistor tip. Like the catheter will have a tip that has the capacity to sense the change in the temperature when the cold saline is going and mixing with the blood in circulation, is inserted to inserted to study the difference in temperature. So that way the value, the temperature difference and the concentration of the dye, all this thing together used to be calculated through the Stewart-Hamilton equation. Calculation was done by the Stewart-Hamilton equation. But this was not very productive. It had its limitations. Complications were seen. Complications like valve rupture, injury, or damage to the pulmonary artery, and interference with the cardiac function was seen. So this method was also not used. It became obsolete. Then what was used very successfully? The third method that was quite successful was the echocardio. What happened in that? Here, Doppler wave, Doppler sound wave was used to study the structures of the heart and calculate stroke volume, cardiac output, all the parameters of heart. But again, its productivity, the reliability was not that great. Now, what is in used most common, it is the magnetic resonance imaging. Okay. Now, this is the most accurate, and that is after Fick's principle, this is the most accurate and widely used. But Fick's principle, it is like obsolete because it is painful, it is invasive. So these days it is actually the MRI which gives us the correct picture to understand and get all the structures of the vessel, structure of the valves, and calculate cardiac output, stroke volume, all this cardiac function. Okay, these are the method to measure the cardiac output. Coming to the determinants of the cardiac function. So, determinants of cardiac output. Okay. To start with, what did we understand in the few minutes back? What is cardiac output? Cardiac output, it is the function of the heart rate and stroke volume. So anything that affects the cardiac output is a result of something that has affected either the heart rate and the stroke volume. Now, heart rate, it is modulated and controlled by the autonomic nervous system. Autonomic nervous system. So, parasympathetic innervation, it will always decrease the heart rate, and decrease in the heart rate is called what? It is the negative chronotropy. Whereas the sympathetic innervation, it always increases the heart rate, which is positive chronotropy. Okay, this is how the heart rate controls. Okay, so this is mainly the determinants, the mainly that is within the body. We are not talking about the external factor. Obviously, external factor, like if a person is scared, if a person is in anxiety, if a person is having anything that has induced vasoconstriction, that will cause tachycardia. That is different. Here, when we are talking about determinants of the cardiac output, we mean the determinant that is within our body, not anything that is inducing the change. Okay, not the external factor. So, autonomic nervous system. Now, coming to the stroke volume. This is having more than one factor, and it is very, very interesting. The stroke volume, it is controlled by the preload, and we have to understand very important thing related to that, which signifies, which means the end diastolic volume. This is 1. Okay. Then second, that is B. It is the contractility. Like contractility of the what? Contractility of the ventricle. Mainly which ventricle? Mainly here it means the left ventricle. Okay. And third is what? Third is the afterload. Now, afterload means the total peripheral resistance. Now, here one by one, we will understand this factor. Heart rate we have understood, heart rate nothing much. Now we will understand the determinants of the stroke volume. So determinants of the stroke volume. So this is a very interesting event that is happening in the body. Okay. So the first one is preload. Now it means end diastolic volume. Usually in the ventricles. Okay, this is the ventricle. I'm not drawing the atrium. So in the ventricle, as a end diastolic volume, as a end diastolic volume, say commonly, for example, it is 130 ml. For example, okay, in a healthy person, say it is 140 ml. Now, this is a normal condition. This is like normal condition, a daily event. Okay. Now, due to some reason, maybe some anxiety, maybe some exercise, anything, due to some reason, this end diastolic volume in the same person, it has increased to, say, by another 30 ml. Okay. And it has become 160 ml. Say, due to sudden exercise. Okay. Example. These are all examples. Due to thing. Now, what will happen? Now, the end diastolic volume is more. Now, this cardiac muscle, what is cardiac muscle? Cardiac muscles are stretchable. Cardiac muscles are stretchable. These are stretchable. Okay. When the end diastolic volume increases, when the end diastolic volume increases, the tension generated due to more stretching of cardiac muscle fiber also increases, right? Meaning what? When the end diastolic volume was 130 ml, after the feeling phase, the ventricular cardiac muscle stretched to a certain extent. There is a generation of the tension. Just stretching I'm talking. I'm not talking about contraction or ejection, anything. Just after the feeling, the end diastolic volume. Now, in that same person, due to some reason, when this 130 ml has become 160 ml, now the ventricles have more blood and cardiac muscle are stretchable. So when the ventricles are having more blood, automatically the stretching of the cardiac muscle will be more, the tension generated will be more, and what will happen? The myocytes, that is the cardiac cells, will exert more force. It will increase the force. It will exert more force of contraction. That is what we call as positive ionotrophy. Okay, so positive ionotrophy. So when the ventricle sense that more blood has come to it than its normal quantity, it will exert more force. more force and the force of contraction will be harder. Why? To pump or eject out more blood. So increase in the stroke volume, increase in the cardiac output. Okay, this is what is called as the pressure tension relationship. So here you see that what is the preload? Preload is the first and foremost determinant of the cardiac output. So preload means end diastolic volume. End diastolic volume, we already know what is end diastolic volume. It is the volume of the blood that is present in the ventricle after the filling phase. We have studied so many times in last two classes, previous two classes. So, say for example, if the end diastolic volume in a person is 130 ml, this is his regular end diastolic volume. Now, all of a sudden, due to something, this end diastolic volume, it increases to 160 ml. It increases to 160 ml. So now there has been 30 ml of blood more in the ventricles. Now ventricles, they are like stretchable. They have elasticity. This cardiac muscle, they manifest stretchability. So when it sees that more blood has come, another 30 ml has been added, it will stretch more. So more stretching means more tension will be generated. Now the calcium will cause more forceful contraction of the ventricle, so that if the stroke volume was 70 ml in normal condition, now the stroke volume will be 80 ml, a phenomenon which is called as the positive inotropy. What is positive inotropy? Increase in the force of contraction, right? So the myocyte will sense it and they will contract harder, forcefully, so that more blood is let out. Now this beautiful relation has been described by the Frank and Starling. They were these two scientists who are who are Frank and Starling. Okay, so they came up with the understanding of and depicting of this preload and end diastolic volume relation, which is called as the Frank-Starling's law. So, in what did they say? They said that under normal physiological condition, like the person is healthy and is of 70 kgs of weight, increase in end diastolic volume will increase preload, which will increase the force of contraction, eventually increasing the stroke volume, which in return will increase the cardiac output. Now, this they called as the pressure. This is the pressure, or rather, the easy way to remember is that why use two terminology? Just one. Volume tension relationship. Now, there is a graph also which explains or which helps us understand what they have proposed. So, this is the graph. On the x-axis, we have the end diastolic volume, like end diastolic volume in ml. And on the y-axis, we have the cardiac output or stroke volume, because anything that affects the stroke volume will automatically increase the cardiac output. Okay, so what does it say? It says that under normal physiological condition, whenever there is increase in the end diastolic volume, whenever there is increase in the end diastolic volume, see, as the end diastolic volume is increasing, the force of contraction is also increasing until a certain point, until a certain level where it is like leveling off, Okay. So the initial explanation that with increase in the end diastolic volume, there is increase in the cardiac output or the stroke volume. This is called as the Frank-Starling law. Say for example, in this condition, the cardiac function normally is working at a point say E. Okay. Now, suppose a positive inotropic agent has been added. Let me draw it again. So just drawing it again. Hold on. So this is the Frank-Starling normal curve with a point A, which is the point at which the cardiac function is working at a normal condition. Now, suppose a positive inotropic agent has been increased. What is used? Now, what is the function of the positive inotropic agent? Anything that increases the contractility, like digitalis or even derivatives of this caffeine, all this kind of drug. So here the same curve will move upward, but its functional point will be normal. It will be in the same line as the normal point. This is due to positive ionotropic agent, and this is the normal graph. Now the same thing, if a negative inotropic agent is added, then the graph will move downward, but the point will remain the same. Like this is B, this is C. They all line in the same perpendicular line, same linear line along with the point at which the heart is functioning. This is like after adding the negative ionotropic agent. This is the graph that is described by the Frank-Starling, and we call it as a Starling graph also. Now here the first line, you remember what we told, under normal physiological condition. So what does under normal physiological condition? It means that it has a limit. There is a limit. It's not that every time whatever amount of end diastolic volume increases within the ventricle, this Frank-Starling law will follow. No, it has a limit. The limit is that limit of the Frank-Starling law. What is the limit? This law will work when the end diastolic volume is max up to 200 to 220 ml. 200 to 220 ml. If the end diastolic volume increases more than 200 or max 220, then the Frank-Starling law will not work. The law will not work. What will happen? In clinical condition where the end diastolic volume is more than 200 or 220 ml, there will be preserved volume. Means preserved volume. What does preserved volume mean? It means there will be accumulation of blood in the ventricles and stroke volume will not increase. So if over a period of time there is like filling of the ventricle and accumulation of the ventricle with the blood, and there is not enough like pumping of the blood from the ventricle, then the heart will stop at the diastole. The heart will stop at the diastole, a condition which is called as the diastolic failure. We'll come to that with the loop diagram later. Okay. Now this basic diagram you have understood, the graph I mean. Tomorrow we will start with the Starling curves and the applied part. Okay. So this is a preload. Now moving on to the details of the Starling curves, we will start tomorrow. We'll start with the curves and also the loop, and then we will continue to the other topic. Now, let's finish this one. The second determinant is the contractility. It is the contractility or the force of contraction or ionotropy. What determines the contractility? When the force of contraction increases, cardiac output increases due to stroke volume. Stroke volume also increases. Okay. For example, anxiety, epinephrine. Okay. Atropine antagonist. Okay. Or caffeine derivative induces positive ionotropy. Okay, induces positive ionotropy. And of course, drugs like digitalis and all that we have discussed. So, similarly, negative ionotropic agents, grief, sorrow. Okay, adrenergic antagonist decreases contractility. These are the agents. Now, apart from this, there are two pumps also which increases the contractility, or rather these two pumps also help in increasing the stroke volume. There are two pumps, two pumps that increases the stroke volume. One is the skeletal muscle pump. Another is the respiratory pump. Now, what happens in the skeletal muscle pump? Here, in the contraction of the skeletal muscle stops the pooling of blood and increases venous return. What does that mean? It means that say this is the veins. Okay, on either side we have the muscle. So we know the veins have got, like, they have got valves. They have got valves. And so this is the muscle on the either side. This is the skeletal muscle and these are the vein. So whenever there is this vein, the blood is flowing through the vein, the blood is flowing through the vein. So during contraction of the skeletal muscle. So when the muscles is contracting, they are squeezing on the veins. They are squeezing on the veins like this, and the veins have got valves. So when they are squeezing on the veins, when during contraction, during the muscular contraction, when the veins are getting more squeezed, the veins are getting more squeezed due to the contraction of the muscle, then what will happen? The diameter of this diameter of the vein is reducing. So the tendency of the blood to stay in the vein is decreased. Now vein pooling means when the blood is stationed or staying in one region. Now due to the contraction of the skeletal muscle, here the blood is thrust forward and is pushed to the venous return. During contraction, the veins are getting squeezed and the blood is thrust to the venous return. They are not stationed. They are not staying in the vein. So since they are not staying in the vein, it is said that the pooling, the staying of the blood in the vein is reduced. As a result of which there is increase in the stroke volume, leading to increase in the cardiac output. This is how the muscular pump works. Now coming to the respiratory pump. So here in the respiratory pump, what is happening? Here in the respiratory pump, what is happening? During inspiration, the intrathoracic pressure increases. So during respiration, the thorax expands, the chest cavity expands, as a result of which the intrathoracic pressure decreases. The arrow is wrong. The intrathoracic pressure decreases because the chest wall is expanding. If volume is increasing, the pressure will go down. Due to which the thorax is expanding sidewise also, lengthwise also. So underneath, below the diaphragm flattens out. So the diaphragm is flattening out. This mechanism, again we will study the respiratory mechanism. So the diaphragm is flattening out and it squeezes the abdomen, as a result of which increase in intra abdominal abdominal pressure happens. So I repeat, when we are breathing in, the chest expands. Expansion of the chest means volume has increased but pressure has decreased. Now when the chest is expanding, it will expand sidewise also, lengthwise also, both up and down. So when it is expanding lengthwise, underneath, below, it is squeezing the diaphragm, and the diaphragm, which in normal condition is arc shape, it will flatten out. So when the diaphragm is flattening out, it will squeeze, it will suppress or exert pressure in the intra-abdominal region. So the intra-abdominal pressure will increase. Now when this happens, it increases the stroke volume, and ultimately there is increase in the cardiac output. This is how the two pumps work. Okay, and the contractility also works. The last determinant, which is the afterload. So first we have studied, first is the preload, then was the contractility. Okay, contractility, we have finished the contractility, we have understood. Now last is the afterload. Now what is afterload? It means the resistance that the ventricles face during ejecting or pumping out blood. The resistance is more from the peripheral circulation, because peripheral circulation includes many structure. So when the blood is being ejected out of the ventricle through the aorta, if there is any hindrance, if there is any obstacle in the pathway, then the ejection or the pumping out of the blood will not be smooth, will not be just like how it is in normal condition. So the afterload, this is the afterload will increase. So the mean arterial pressure and total peripheral resistance determine the afterload. And afterload is very, very important, because afterload, we have studied three loads, three determinants: preload, contractility, afterload. So unlike preload and contractility, whenever there is increase in the afterload, there will be decrease in the stroke volume, decrease in the cardiac output. So when, point to remember, ever there is increase in afterload, whenever there is increase in afterload, the stroke volume decreases and cardiac output decreases. Even more important point to remember is that if in any condition the point to remember, preload, if in any condition the preload and contractility remain same, but after load increases, then stroke volume will decrease and cardiac output will decrease. Now, this point is very, very important to remember. Even if preload and contractility, which are also two important determinants of the stroke volume, they remain same, but after load increases, then the stroke volume will decrease, cardiac output will decrease. So we are to remember this like this. This is our stroke volume. This is after load. This is preload and contractility. So what does afterload do? Afterload, it decreases the stroke volume. Preload, it increases the stroke volume, and contractility, it increases the stroke volume. And if the preload and contractility are more, yet the afterload is less, then also the stroke volume will be less. Okay, the stroke volume will be less. Resultant is drop in systolic blood pressure. The systolic blood pressure will decrease, and since the afterload is more, increase in the diastolic blood pressure. This, of course, we will understand in the next. Okay. Now, next class we will start with the Starling curves, which is an extended understanding of what we discussed today. Now, coming to the last part of it, as I mentioned you then, it is the, now we have understood the three factors that increases and determines the stroke volume and how stroke volume influences the cardiac output, because it's a very, very important factor of the cardiac output. Cardiac output is hugely influenced by the stroke volume and heart rate and stroke volume from all parameters. So we have understood the loop also. Now in context to that, these are the three conditions that is affecting the volume pressure loop. What is this? This is our volume pressure loop. First example is increased preload. So here the first example, increased preload. So here you see this solid line, the violet solid line, it is the normal condition, like the normal loop, the parts that we studied. The dotted lines here, these are like the abnormal extension, the deviation from the normal condition. So increased preload, this 0.4 is our end systolic volume, like the amount of the blood that is there after the maximum ejection, like rapid ejection, slow ejection, after that what is remaining. Okay, 0.1 is actually end diastolic volume. So here you can actually see that the, what's the different pen? Okay, the preload has increased. The two dots are more. Okay, so if preload has increased, what will happen? The contractility, the force of contraction will increase. So A, increase in preload means increase in end diastolic volume. So what is happening? The loop is widened and moved to right. That means what? The force of contraction is more. It rather should write the force of contraction has increased. Okay, so here you see the force of contraction, it has increased and more amount of blood has been pumped into the periphery and stroke volume increased. So obviously the cardiac volume also increased. So this is like the direct example or depiction of the Frank-Starling law with no other abnormality in it. Coming to the second diagram. The second one is, as we can see here, it is a condition where the afterload has increased. Afterload increased means increase after load, means increase in the total peripheral resistance. There is some obstacle, some hindrance in the pathway in the ejection of blood. Therefore, the peripheral resistance has increased. So, when the peripheral resistance has increased, the heart is, this is our end systolic volume and this is our end diastolic volume. So, the end diastolic volume is same like normal. Now, since the total peripheral resistance has increased, the afterload has increased, the loop has moved up. Moved up means it is doing more work. It is doing more work. The ventricles are exerting more force of contraction. The contraction of the ventricle has been more. The work done by the ventricles is more. But see the area inside this deviated loop, the stroke volume. The stroke volume has become less. In normal condition, what is the area? In normal condition, what did we study? This is the stroke volume, right? This normal area, it depicts the stroke volume. But when the contractility, when the afterload has increased and the contractility has increased, though the afterload has increased and contractility also increased, yet the resistance is such that the ventricle cannot pump. Even after increasing its force of contraction, the ventricles are not able to pump as much as blood it should pump to the periphery. So there is decrease in the stroke volume. So what stands out? When the afterload is increased, there is decrease in the stroke volume as we see in the loop. The third example, the third example, the third condition, increase in contractility. Increase in contractility. So, looking at the graph. So, here this is the end systolic volume. This is the end diastolic volume. The end diastolic volume has not increased. The preload has not increased. And there is no mention of the afterload also. That means the afterload is also normal. So, anything, for example, there has been a usage of like positive inotropic agent, or the person is running faster, the person is like scared, the person is like excited, anything that has caused like more contraction, more forceful contraction of the ventricles. So here you see the force, the curve, the loop, it goes taller, the loop, it goes taller, the loop has become taller in size, whereas the end systolic volume has decreased. Why? Because with the increase in contractility, the amount of blood pumped to the periphery increases. Thus, increase in the stroke volume leading to increase in the cardiac output. So overall, what we studied from the determinants of the stroke volume, these graphs are implications of that. So in the third case, what did we see? We saw with the increase in the contractility, more blood is being pumped to the periphery. The stroke volume, the cardiac output is more. Say after normal pumping or normal ejection of the blood, say for example, if there are in normal condition, if there are 50 ml of blood that is remained in the ventricle after normal pumping of the blood, in case of increased contractility, the and systolic volume decreases from 50 ml instead of 50 ml because more blood got pumped to the periphery. So the end systolic volume instead of 50, it reduces less. Say it reduces to 25 ml. This is an example. So whenever there is increase in the contractility and there is no afterload, no other peripheral resistance, no other factor that is affecting the blood vessel, then the amount of stroke volume, amount of cardiac output increases and the end systolic volume decreases. Okay. So this graph for us is to remember the various determinants that we have studied so far. So now this is all about our cardiac output. We have started with the definition. We have started with the extended part of the Vegas diagram. We understood the various phases in the curve phases in that Vegas diagram. It's abnormal condition related to the abnormal condition in which we studied two examples, reurgitation and stenosis, the cause, how it affects and why it affects. Then we moved on to understanding the pressure volume loop, its normal condition. Then we understood the cardiac output, measurement factors, lastly the determinants, and then the determinants that we studied, we correlated with the graphs. Okay. Tomorrow we are going to start with Starling curve. After Starling curve, we will study two conditions of the loops and then we will move on to the arterial blood pressure. So this is all for today. I will see you guys tomorrow. Thank you.